10 p.m. in Brazil, okay, right?
Yeah, 10 p.m. and 2 minutes.
And 2 minutes, okay.
Yeah.
Okay, it's a great honor for us to introduce Marcela Salvadori this night. She will talk about the highlights on gynecological tumors in ASCO meeting, and also she will talk about her experience in the ASCO idea. We have to remember that Marcela is a recipient from the idea, and this year she is one of the out of 4 Latin American oncologists who won this award. Marcela is working now in Clinica in Salvador, Bahia. She has been in Canada as observership in the programs of lung and breast cancer at the Margaret Princess Hospital, Toronto, and also in Sao Paulo. She has several presentations in international meetings, and also she has papers in our field in oncology. Thank you very much, Marcela, for your collaboration, for your participation, and we hope we will learn about you.
Thank you very much for this opportunity, Dr. Francisco. I'm going to introduce me again. I'm Marcela, and I did all my medical training in São Paulo at Camargo, and nowadays I'm a medical oncologist and I work at Clinica in Salvador. I'm going to put my presentation here. Just a second to... Oh, just a second, Dr. Francisco. I may. Just a second that, oh, I need to put my presentation here. It's
just
okay?
On the wide screen, it's okay.
Here? It's
yes.
Okay? Oh, great.
Excellent. Go ahead.
Okay, let's go. This is my disclosures. I don't have conflicts of interest to declare. And I'm going to start to talk about abstracts in endometrial cancer. Just a brief background. Endometrial cancer is the most common gynecological cancer in developed countries. In Brazil is the second one because the first one is cervical cancer. The risk factors including increased estrogen exposure, hyperinsulinemia, and hereditary syndromes. And the incidence probably is increasing due to life expectancy and obesity. The majority of the endometrial cancers are caused by sporadic mutations, but range to 5% are caused by germline mutations. And Lynch syndrome is the prototypical of genetic syndrome in endometrial cancers. And when we have alterations in proteins of the mismatch repair. In endometrial cancer, like 15 to 20% of endometrial cancers are associated with mismatch repair deficiency due to germline mutations like Lynch syndrome or somatic mutations. We know that the initial tumors, endometrial tumors, we treat with surgery and radiotherapy. But in advanced or recurrent endometrial cancer, the first line, the standard of treatment is platinum doublet, but in second line and the other lines, we don't have optimal treatment. The objective tumor response in this setting is less than 20%. We need new drugs to treat these patients, and PD-1 blockaded or immune checkpoints are the drugs can help us to treat these patients. Van der Streeten demonstrated 83% of the endometrial primary tumors have the PD-L1 expression, and most 100% in the metastatic tumors had the PD-1 expression. In this setting, the PD-1 blockade can be a good drug to treat these patients, and we have this study that is the Keynote 028 that patients with solid tumors with PD-L1 expression are treated with pembrolizumab, and this is the cohort just with endometrial cancer. And what we see that 3 patients had partial response, and 2 of these patients had durable response. Ongoing this response in the cutoff of the study, and 25% of these patients have had decrease of the target lesions. In this way, immunotherapy to endometrial cancer is a promising treatment. This other study, remember that 15 to 20% of the patients with endometrial cancer have mismatch repair deficiency. We have 3 cohorts, one with mismatch repair deficient colorectal cancer, mismatch repair proficient colorectal cancer, and mismatch repair deficient no colorectal cancer. And the 2 of these patients, they had endometrial cancer. And the objective response rate in these patients were 71%. Again, chemotherapy in patients with endometrial cancer and mismatch repair deficient is promising treatment. This is the first abstract from ASCO that I want to present to you. In this setting, immunotherapy in endometrial and advanced endometrial cancer is a phase 2 trial, and is an open-label, multi-center, phase 2 non-comparative trial with the 2 cohorts: advanced endometrial adenocarcinoma with MMR mismatch repair proficient, and the other cohort, MMR deficient. These 2 cohorts, we have to pay attention that the patients MMR deficient can be the first line of these patients. They don't have to do the standard treatment first, but the patients MMR proficient, they have to have 1 line of chemotherapy prior. All these patients received durvalumab in the dose 1,500 milligrams each 4 weeks, and received the drug until PD. The objectives of the study, the primary objective is the objective tumor response rate according to the immune resist. And this is the other objectives of this study. We have to pay attention that in MMR deficient cohort, we have patients with grade 2 tumors and more endometrioid histology. Then the proficient cohort, we have more grade 3 patients and with serohistology, like 31%, or in other words, more aggressive tumors, MMR proficient. And the overall tumor response were 43% in MMR deficient and just 3% MMR proficient. What is the message of this study? That in patients with advanced endometrial deficient MMR, we have a response rate of 43%. But in patients with proficiency of MMR, the immunotherapy is minimally activity. We have a good profile of adverse events, and we need, with these results, we need to explore the use of immunotherapy in endometrial cancer, especially in patients with MMR deficiency. We have other interesting abstract phase 2 study of avelumab in patients with microsatellite stable, microsatellite unstable, EPOL mutated patients. But the authors wanted to include the patients with POL mutated, but in fact, they not include these patients. And we have 2 cohorts again, the patients with recurrent or persistent endometrial cancer, the stratification in mismatch repair deficient or proficient by immunohistochemistry, and these 2 cohorts, the patients will receive avelumab each 2 weeks until disease progression. The cohort of MMR proficient was closed by futility, but we have the analysis here. The primary endpoints were progression-free survival more or equal 6 months and objective response rate by RECIST. The patients in this study can be prior therapies, but they can't receive prior immune checkpoint blockade. And this is the results. The overall response rate in MMRD cohort was 26%. In the MMRP cohort was 66%. And PFS 6 was 40 for the MMRD cohort and 6% for MMRP cohort. I want to detail one of the exploratory points that is very interesting, the assess MMR status using PCR and target NGS for all the tumors and correlate with the findings from immunohistochemistry. And what we see with these results, that in MMRP, the proficient patients, the immunohistochemistry, 13 patients got PCR, and 13 patients are MSS by PCR, what is the same result of immunohistochemistry. By NGS, 15 of our 16 patients got NGS, and by NGS, all the 15 patients are MMRP. In other words, immunohistochemistry did not miss any case of MMRD determined by PCR or oncopanel or by NGS. This is very important because we have access to immunohistochemistry, and immunohistochemistry is assay more cheaper than the others assay. On the other hand, in the cohort MMRD, we have 15 patients, and of these 15 patients, 12 got PCR. And by PCR, 3 patients that were MMRD cohort in PCR are MSS. One of these 3 patients had avelumab partial response and was MMRD by oncopanel in concordance with immunohistochemistry. The remaining 2 patients are MMRP and don't have response to avelumab. In other words, PCR missed 1 case of avelumab response that was MMRD, both immunohistochemistry and oncopanel. In this way, we have different overall rate response by the assay that we use to know if the patient is MMRD or MMRP. We can see here that our overall rate response range 30 to 22% and 5 to 12% by the assay that you use to know if the patient is MMRD or MMRP. Take home message. MMRD by immunohistochemistry correlates with the response to avelumab. The patients that are deficient, avelumab did not show activity worth of further to the patients to MMRP. These findings support the routine use of immunohistochemistry to determine if the patients are MMRD or MMRP in endometrial cancer. Observed response to avelumab in MMRD and MMRP tumors was different depending on assay used to define the MMR status. Okay, now to end the endometrial cancer abstracts, I want to share this abstract, the keynote 775, a randomized open-label 5-3 study to evaluate the efficacy and safety of levantinib and pembrolizumab versus treatment of physician's choice in patients with advanced endometrial cancer. This study is enrolling patients and is a phase 3 to test the efficacy of immunotherapy for endometrial cancer. Now we are going to move to ovarian cancer. Just a brief background: ovarian cancer is the second most common gynecological cancer, and the most common cause of gynecological cancer death in United States. The risk factors include increasing age, infertility, endometriosis, and cigarette smoke. The majority of ovarian cancer are caused by sporadic mutations, but 15% of the patients have BRCA1 and BRCA2 mutations. In this setting, we have new drugs, the PARP inhibitors. And what we know that for women with ovarian cancer, chemotherapy is still critically important. But for women with ovarian cancer in BRCA mutations, PARP inhibitors are critically important. This study, SOLO-1, changed practice, is the study of maintenance of PARP at first line of treatment, and the approval of the drug, the FDA approval olaparib, is by this study. But we have to think about this because this is a maintenance after first line of treatment. But we have to think about what is the best sequence for our patients. Is the first line maintenance, is recurrency setting? And this study, and this is the question. Do you need chemotherapy to treat recurrence in these patients, the BRCA mutated patients? Probably not. And this study, the SOLO-3, answered this question. Olaparib monotherapy versus chemotherapy for germline BRCA mutated, platinum-sensitive relapsed ovarian cancer patients, the phase 3 SOLO trial that was presented in ASCO 2. And what we see, that the patients, they have to be in the platinum-sensitive setting. They have to have 2 or more previous line of platinum-based chemotherapy, and they are randomized to olaparib versus no platinum chemotherapy. And this is the point. The control arm is no platinum chemotherapy. If I have a patient platinum sensitive setting, why I have a control arm no platinum with no platinum chemotherapy? We have to pay attention in this. And the primary endpoint is overall response rate by RECIST. And what we see that the patients are really treated, how can we can see, and the overall response rate was 72% to olaparib versus 51% to chemotherapy, with a statistically significant P equal 0.002. 0.002. And this benefit we saw in the other tables with more treated patients. These are the PFS curves with benefit to olaparib again with significant P 0.013. 3 months to olaparib versus 9 months to chemotherapy. It's important to pay attention in adverse events because we have different adverse events than other randomized trials with olaparib. We have 4 patients with MDS AML and in the arm of olaparib, and 3 patients with the MDS AML in the chemotherapy arm, but two of these 3 patients receive PARP inhibitor in sequence. And we have new primary malignancies that we don't know about this in other trials. And finally, the quality score was no clinically or statistically significant olaparib than chemotherapy. Take-home messages. Olaparib is a treatment option for recurrent platinum-sensitive ovarian cancer in BRCA-mutated patients. It's promising, but we can't change our practice yet because the control arm is with no platinum chemotherapy. We expected quality of life, the scores quality of life, better with olaparib, but we didn't see this. Olaparib has different adverse events, but not exactly less adverse events, and has the commodity of oral drug. And now CLIO, that is other abstract, a randomized phase 2 study evaluate efficacy of olaparib monotherapy versus physician choice chemotherapy, but now in the setting of platinum-resistant ovarian cancer. This is a background. We know that in this setting, we have 4 types of chemotherapy that were tested in randomized trials with overall response around 15%. They are paclitaxel, PLD, topotecan, and gemcitabine. And single-agent PARP inhibitor therapy, FDA approved in germline BRCA-mutated relapsed ovarian cancer, but with 3 or more prior lines, but 2 single-arm phase 2 trials with olaparib and rucaparib. And here we see the response rate of these drugs that is around 25% to 31%, but in BRCA mutated, we don't have data in patients that don't have BRCA, we don't have data in patients BRCA wild type. And the CLIO study, we have the eligible criteria: relapsed ovarian cancer, at least 1 previous line of chemotherapy, the epithelial histology, measure of disease, and previous PARP inhibitor was allowed. We have two cohorts, one of platinum sensitive, that the data is not mature, is not the goal of this abstract, and the other cohort, that is the goal of this abstract, platinum resistant, with 100 patients, and the patients that are primary platinum refractory disease, in other words, relapse during or last 28 days after first platinum, were excluded of this group. And the patients were 2-to-1 were randomized to olaparib versus physician's choice chemotherapy. This is the secondary endpoints. Is the goal of the current report, and the secondary endpoints are objective response rate, PFS, clinical benefit rate at 12 weeks, and duration of the clinical benefit. The baseline characteristics, we saw again, the patients are heavily treated. 15% and 42% the patients had 4 or more prior lines. And we have a problem with the 2 groups, because in the group of olaparib, we have 21% of patients BRCA mutated. And in the chemotherapy group, we have just 3% of BRCA mutated. In other words, imbalancing in frequency of no BRCA mutation between both groups. This is the objective response rate, and is 18% in olaparib group and 6% in chemotherapy group with no statistical significance. And this is result for me, it's more important. BRCA wild type in olaparib group, 13% of overall response rate versus 6% in chemotherapy group. This is the curves of PFS, and we don't have difference between olaparib and chemotherapy group. This is the adverse events, and what we see that more anemia for olaparib group, more neutropenia for chemotherapy group, and more vomiting for olaparib group. Take-home message. Olaparib is option for recurrent platinum-resistant ovarian cancer, especially in BRCA mutated patients. In BRCA wild type, we have 13% overall response for olaparib versus 6% of chemotherapy. It's not a huge result. The issue of the study is that the groups are imbalanced for BRCA mutated patients. And again, olaparib, different toxicities from chemotherapy, but not less toxicities and accommodated overall drug. And the last abstract that I will present to you is an interesting abstract about patients, elderly patients in our contest. To treat more and more elderly patients, we have elderly patients, we have patients with ovarian cancer stage 3 or 4 and vulnerable. And these patients were randomized to receive the standard of care carboplatin plus paclitaxel every 3 weeks versus carboplatin alone, or weekly paclitaxel plus weekly carboplatin. The question is, for these elderly patients, less treatment is more? And we are going to have the answer in this study. We have to remember that 90% of these patients in all arms don't have a suboptimal surgical cytoreduction because the amount of tumor, because of the comorbidities, because of about the performance, comorbidities, and the disease. And these are the curves. And we have benefit of overall survival to the standard chemotherapy, carboplatin plus paclitaxel, it 3 weeks. What is the message? You have to know what is your goal in the treatment of the elderly patients. If your goal is overall survival, you have to use the standard of care. And to end my presentation, I want to share with you my experience with IDEA. It was my first time in ASCO, at ASCO, and I'm impressed with a lot of information that I can learn in just 5 days. I want to stay in all the sessions in the same time, but unfortunately, this is not possible. But it was very interesting. I participate of mentoring sessions, the global journal editors mentoring session with Dr. Eduardo Casapi that we can discuss about clinical research in Latin America, about how I can publish articles now on, and how I can start research in my community. Other very interesting session was the 2019 Women's Network Center that we had sessions about career, about employment, about wages, that are things that I don't usually think, but I have this moment to think about the things, these important things, and I encourage all the women to attend to the sessions. Other important sessions were the education session, especially HPV session, and etiquette sessions about COPE and about lung cancer. After ASCO, I traveled to Maine, and my mentor was Thomas Openshaw. I can meet and visit his center and know how he do oncology, and it was very interesting, and I came back to Salvador with a lot of ideas to modify our practice and to improve our research program. Network for me is the most important things with IDEA, and it was my goal with IDEA. I met a lot of people, my colleagues of IDEA, my mentor, and a lot of people, the nurse research of my ATA, and these people opened my mind for improve my practice here in Salvador. I encourage all the young oncologists to try. And this is my last slide with all recipients of IDEA. And I wanted to thank my colleagues and Dr. Francisco for this opportunity to talk to you about gynecological cancer. That is, I have a particularly interest, and to talk about IDEA. That was a wonderful experience for me. Thank you. And I'm open for questions.
Maria, thank you very much for your excellent talk. And we have 2 questions. The first is from Ana Castrita from Mexico.
Yes.
She asked about how is the access for the panels for MMR or BRCA? And congratulations for your IDEA award.
The access in Brazil, Dr. Francisco, is this the question? The access for
Yes.
Okay.
Do you have access for these panels?
We here in Brazil, we have the access. It's easy to have immunohistochemistry. We generally can do for all the patients, but GNS we don't have access in the public system and private system, just if the patient pay to them.
Okay.
Because of this, I think it's very important, this abstract, because we can use assay that we have access to know and to know the patients that will respond to our therapy.
Thank you. And do you have one more question? Is from Brazil, Dr. Alfredo Barreto.
Okay.
It's in Portuguese, but what about the mechanism, the molecular mechanisms to explain the response to avelumab in patients with DMMR and MCRC, in patients with metastasis in...
What is the mechanism?
Okay,
Oh,
yeah.
the mechanism.
What is the molecular mechanism to explain?
Yeah. I think that we have the deficient MMR. They have more mutations, more antigenous, more neoantigenous. And I think this is important to respond to immunotherapy. By more mutations, they are more mutated patients, and this is the mechanism to respond to immunotherapy.
Okay, more questions? I think your talk was very clear, very informative. Again, I would like to congratulate Marcela, and we hope you will be in next time we will have with new talk from you with your experience in Brazil and with your experience in IDEA. And thank you very much, everyone, for your participation. Marcela, see you soon.
Thank you, Dr. Francisco, again for this opportunity. I'm very happy to talk with you today. Thank you. Thank you very much. Thank you all for the questions. Thank you all for your kind attention for my presentation. Thank you again.
Thank you.